presentation by talking about the problem identification. Primary open-angle glaucoma, or also known as POG, is a significant global health issue. It is the most common form of glaucoma, affecting about 2% of the people over the age of 40 years old in the United States, which translates to over 2.5 million individuals. Shockingly, at least 25% of these cases go undetected, leading to potential irreversible blindness. Worldwide, approximately 45 million people are affected by open-angle glaucoma, with about 4.5 million of these individuals being bilaterally blind. The primary challenge with POG is its silent progression. It often goes unnoticed until substantial vision loss has occurred. This underscores the importance of early detection and management to prevent severe outcomes.
Patients with primary open-angle glaucoma are mostly asymptomatic. Objective clinical findings include symmetrical enlarged cup-to-disc ratio greater than 0.5, cup-to-disc ratio asymmetry between the eyes of 0.2 or more, highly asymmetric cup in one eye, or elevated intraocular pressure. The abnormal clinical findings are often found in both eyes. Typically, patients only present with symptoms in the late stage of the disease. After more than 40% of the nerve fibers are damaged, patients may experience a gradual loss of peripheral vision or tunnel vision. If left untreated, patients can have irreversible blindness. Risk factors include non-modifiable factors, including older ages, older than 60, being African or Hispanic ethnicity, or having family history. Modifiable risk factors include elevated intraocular pressure, myopia, having diabetes, hypertension, and being on a prolonged corticosteroid use.
Okay, so for problem focus, we focus on early detection. So this is the importance of regular eye examinations, especially for the high-risk population. So this includes individuals with an affected first-degree relative, persons who have diabetes, older individuals with African or Hispanic ancestry. Screening may also be warranted in patients taking long-term oral or combined intranasal and inhaled corticosteroid therapy. We should always focus on the quality of life, so the impact on daily activities and mental health due to vision loss, as well as management challenges. This includes adherence to treatment, monitoring disease progression, and managing side effects of medications. So as far as the grading scale goes, the USPSTF grades screening for glaucoma as a grade I, and the population for this are asymptomatic adults 40 years and old. And the reason that it's grade I is because there's current evidence that it's insufficient to assess balance of benefits and harms of screening for patients with primary open-angle glaucoma in adults.
So here's the current understanding of pathophysiology. POG is a neurodegenerative disorder which causes a loss of retinal ganglion cells and optic nerve fibers. POG is the most prevalent subtype of glaucoma. Few gene mutations have been identified to be the cause of POG, but less than 5% of all cases are associated with gene mutation. Most cases are thought to be caused by a complex disease processes related to multiple predisposing genetic variants. Genome-wide association studies reported over 100 novel variants to be associated with glaucoma development. Mutations are seen in genes such as MYOC, OPTN, and TBK1 have been implicated in POG.
Okay, now I'm going to go over the epidemiological data. So when we examine the epidemiological data of POG, we see a global prevalence of about 2 to 3% in people over 40 years old. As Pooja mentioned, the disease is disproportionately affects certain ethnic groups, such as the higher prevalence in African and Hispanic populations. The data shows that 2.2% of white adults over 40 are affected compared to the 5.7% of Black adults. Age also plays a critical role, with the incidence increasing significantly as people age. Interestingly, there is also a gender disparity, with males experiencing a 36% higher prevalence than females. Key risk factors include elevated intraocular pressure, family history, and systemic conditions like diabetes and hypertension. The data also highlights the need for targeted screening and intervention efforts, especially with the high-risk population.
In terms of current state of practice regarding primary open-angle glaucoma, as Pooja mentioned, USPSTF classifies primary prevention for glaucoma as insufficient because of the insufficient evidence. However, because glaucoma can cause irreversible vision loss, patients with risk factors should be screened and referred to an eye specialist. And also, Medicare covers evaluation in patients with high risk factors. Up to 1/2 of patients are undiagnosed because of a diagnosis often requires monitoring over years to document changes, suggesting primary open-angle glaucoma. Gold standard diagnostic test is tonometry, which can measure the cup-to-disc ratio and also intraocular pressure. But newer technologies include the optical coherent tomography, which analyzes the light reflected off the fundus, and also visual field tests with brain-computer interface, which can analyze the electrical brain activity to visual field stimulation. The goal of therapy is to prevent further deterioration of vision from disease progression by lowering intraocular pressure. Initial treatment includes either medical treatment or laser treatment. For medical treatment, the eye drops are used. The preferred therapy is using the prostaglandins because of its effectiveness in lowering intraocular pressure, and it has less systemic side effects. Whereas beta blockers can be used as an appropriate treatment, considering the cheaper cost, but it's not as effective as the other treatment, and it can cause systemic side effects like exercise intolerance, depression, and sexual dysfunction. Laser therapy works by improving the drainage of the aqueous humor through the trabecular meshwork. The pros of this therapy is that it only affects selected pigmented tissue in the eye, and it has a fewer adverse events. And meta-analysis actually comparing the laser treatment to medical treatment, they didn't really see any significant difference between the intraocular pressure control. So surgeries are only recommended for patients with severe vision impairment or when other treatments fail. However, this comes with a lot of risk, including cataract formation, scarring, and vision loss. The neurosurgical approach includes minimally invasive glaucoma surgery with the purpose of achieving eye drop-free glaucoma management, but it is still under investigation.
All right, so these are the practice guidelines that are updated. So the American Academy of Ophthalmology has their own guidelines. They recommend regular comprehensive eye exams, including intraocular pressure measurement, optic nerve assessment, and visual field testing. So the European Glaucoma Society has their own guidelines as well. They emphasize personalized treatment plans on disease severity, patient preference, and risk factors. And then we have treatment algorithms. So the first-line treatment usually involves prostaglandin analogs, followed by beta blockers, alpha agonists, and carbonic anhydrase inhibitors. So last kind of resort is the selective laser trabeculoplasty. And this is where a form of laser surgery that is used to lower intraocular pressure by laser beams to go open up the drainage tissue to help increase the amount of drainage from the eye. So as you can see the picture here, it shows the trabecular meshwork, and then there's a laser that is beamed there, and it helps to kind of open up more room for drainage and thus reducing intraocular pressure.
So now I'm going to go over the gap analysis, which is literature versus clinical practice. First and foremost, there's a variability in adherence to practice guidelines among different healthcare providers and regions. Per the USPS task force, there's a grade I recommendation for screening for glaucomas who are asymptomatic over the age of 40. However, it's important for providers to consider screening high-risk individuals with first-degree relatives of glaucoma, advanced age, and those of African American and Hispanic populations. There's several barriers to screening and implementation, which includes the underdiagnosis due to lack of symptom in early stages, a lack of access to specialty and ophthalmologists, and an increased cost of screening technologies, surgical interventions, and medications. In addition, there's several barriers to treatment. First is adherence issues, non-compliance with prescription treatment regimens due to side effects, cost, or lack of understanding, which further advances the progression of the disease, and also costs. There's inadequate insurance coverage for medication, laser therapies, and surgical interventions.
For hot topics and needed research in regards to POG, current hot topics are neuroprotection. So there is some investigation into agents that protect against retinal ganglion cells from damage, as well as some genetic therapy exploring gene editing, like the CRISPR for treating POG. And that's kind of coming out of the University of Pennsylvania at the moment. There's also some research in the microbiome, specifically studying the role of ocular and microbiome in the glaucoma pathogenesis. From my research, the neuroprotection is a stronger hot topic that's being a little bit more heavily investigated, and the other genetic therapy and microbiome are just like doctoral projects with like theses. There's actually hasn't been huge strides when it comes to these hot topics, but neuroprotection has a lot more investigation and background and support from larger agencies. Needed research includes like biomarkers, identifying if there are reliable biomarkers when it comes to early detection and monitoring the disease progression, as well as like personalized medicine, for phenotypic profiling, and assessing the research in regards to like the long-term outcome of the MIGS procedure, if it's safe and effective, and if it's something we can continue to recommend for our patients.
Based on what we went through about primary open-angle glaucoma, we came up with 3 different pickle questions. The first one is, in patients with newly diagnosed POG, does initial treatment with prostaglandin compared to beta blockers result in better intraocular pressure control and visual field preservation? The answer is yes. Prostaglandin treatment is actually known to be more effective in lowering the IOP, as well as have less side effects than beta blockers. Second question is, in patients undergoing microinvasive glaucoma surgery, does the use of intraoperative optical coherent tomography compared to standard surgical technology improve surgical outcomes and reduce complications? The answer is yes. Third question is, in adults age 40 and above with no prior history of glaucoma, does routine primary prevention screening for primary open-angle glaucoma compared to no routine primary prevention screening reduce the incidence of advanced glaucoma and associated vision loss? This is something that needs to be answered. Currently, we don't have enough evidence to prove if the primary prevention of glaucoma is effective in improving patient outcomes. However, this is an important question to be answered to improve the patient outcome and preserve vision.
So this is the conceptual map. So as far as short-term goals go, it's to develop non-invasive biomarkers for early glaucoma detection, increase awareness about the POAG. So this can be done through community outreach programs, provide training for PCPs on early detection, as well as conducting clinical trials to assess the efficacy of new medications. So this includes train healthcare providers on treatment initiating, standardized treatment protocols based on the latest guidelines. And then as far as long-term goals go, it's to establish gene therapy as a viable treatment option enhance diagnostic techniques, integrate new tools into routine clinical practice, as well as create personalized treatment plans using genetic and biomarker information. And then last but not least, it's to enhance the quality of life, as that's a big problem focus for POAG patients. So this is assessing the psychosocial aspects as well as providing resources for rehabilitation.
Thank you.
Bye. Bye, thank you.
Thank you.